questions? Any thoughts? I see one hand. Yes, ma'am.
Thank you, Dr. Dawes. I think that your discussion was amazing. And I don't have a question, but I just want to tell you this is a totally different way, a totally different perspective of looking at the challenges that we have been facing today. So we so appreciate this discussion today. Thank you.
I appreciate it. Thank you.
Thank you. One of the things I've been doing for years is when new providers come onto the reservation, I think they need to have a historical context as far as, and federal Indian health policy is why Native Americans are in the status that they're in right now. So I really appreciate this. Thank you so much.
My pleasure. Thank you.
Hi, good morning. My name is Zina Ahmed. Thank you so much for the presentation. It was truly an honor as a health policy student at the YSPH, so at Yale. Thank you. So a question that I do have is, a lot of the times marginalized communities are not addressed in the sphere of, I would say, in health policy. I've testified a couple of times in the state of Connecticut addressing those concerns. So how would you, in sort of the realm of health professionals as well as sort of like aspiring students, like how would you address the policies for these specific marginalized communities?
So you're talking about at the educational level, or are you talking about in your advocacy?
In the advocacy.
Okay, so the way it depends. I mean, there's no one size fits all approach, obviously, right? We're dealing with. I mean, if you're coming from New York, if you're on Long Island, for instance, I know they have multiple townships and cities with their own competing infrastructure, right, and system. And so I think it's first understanding that system that you're operating in. It's very interesting to me, right? I'm not saying everybody has to go and do political science, but it does take understanding your jurisdiction's policy, understanding how they have worked over time, understanding some of those main tenets, as we mentioned, with confederalism, right? So for instance, we're working with St. Petersburg. We'll be working with Cleveland, Ohio, and we've been working, of course, in Atlanta, Georgia. And one of the ways that we approach this after we engage community members, right? Because we believe that the people who are closest to the pain and the problems should be the ones leading the solutions, right? And they should be telling us what they see as their biggest issues and what are their biggest priorities that they want to address. So once we've done that, once we've figured out, okay, transportation, for instance, may be an issue, right? Or the lack thereof. Then we work with these communities to figure out, okay, what are the local policies, right, that are on the books that have been driving what we see, the results that we see currently. We then look at preemption issues. We're looking at how, states have taken over this particular area, and every state is different. So once we understand that, and we've understood how they've worked, the levers of power, if you will, over time, then we craft what we do is craft an agenda. And I talk about how we've done that in my second book, right, which spells it out in chapter 7. But essentially, you have to understand and determine whether the inequity that you are trying to resolve is avoidable. Is it unjust? Is it systemic, right? Once you've made that determination based on the existing laws, based on the policies and so forth, then what we have done then is to go from that point into engaging stakeholders that we maybe haven't traditionally aligned ourselves with. So obviously I'm coming from Georgia, and we have, Republicans and Democrats at different levels of power, Democrats in the city, in Atlanta, and at the county level, Republicans at the state level. How do we then politically, with our political acumen, as best as we can, engage these individuals? And we believe in meeting people where they are, right? So there may be language that I use with one group versus the other group, because I know that this may be a trigger for one group versus another, right? But from there, my goal is to keep them at the table as long as I possibly can to get an investment interest, if you will, in the project that we're pushing for. And it's precisely that strategy that we did with the Affordable Care Act, right? With the Mental Health Parity Act, the Genetic Information Non-Discrimination Act, keeping people at the table, making sure that these stakeholders that haven't really partnered up in the past on these issues of equity see an investment value in remaining at the table. I can go into more about exactly how we've done that, but I don't want to take up too much time.
No, I
So that's
appreciate
okay.
it. Thank you so much.
So hopefully that helps a little bit.
Yeah, it is. Thank you.
You talked a lot about the political determinants of health. I'm a family physician. I work in a rural area of Northern California. I'm wondering how the political determinants of the people in politics, Satcher Institute, can help us do battle with the commercial determinants of health. Since some of our biggest, like for lack of a better word, they're almost our enemies. The insurance companies, the pharmacies. I work in a tribal community where in a population of several thousand, we have 271 insulin-dependent patients, and the changes in insulin cost the tribe $800,000 in 1 year if we didn't switch. How do we battle those interests that are prominent in terms of providing adequate health care, insurances, coverage, and medications? Thank you.
Thank you for that question, because it is one that I have struggled with. And actually, it's the third book that I'm working on right now about commercial determinants of health, right? And it's very fascinating to me because I do believe the political determinants of health really are the instigators that empower these results. But I guess the way that I would analogize this is to think about the political determinants of health being the hand, right? And the commercial determinants of health are the glove, really. And they work in tandem with one another, like we've seen, right? But again, the hand has the power over the glove, right? So to your point about how do we work to address their impact? Well, I know there are folks who say, they're on one far extreme saying we've got to just eliminate capitalism. I don't see that happening in this country. So my approach is that, let's think about how they have worked, right? How do they operate? And so I tend to bring in these groups, and I'm trying to study why is it that we've had difficulty getting corporations, getting different healthcare companies to really move that needle in a manner that is going to be substantive, right? Instead of the superficial that we have seen throughout the course of history. So I think for me, it's understanding, let's say, depending on, of course, the structure. Is it a publicly traded company with investors, right? And how do you get those investors then when the senior management is trying to figure out how to appease the board, appease the investors? How can they work then to move that and show that health equity is profitable? My agenda is right now, as we are working on different models, especially payment and delivery system reforms, I know many of these commercial interests in healthcare right now are looking at CMS in particular, and they're looking at what CMS is doing to integrate equity in many of these payment models. So I am really interested in getting these payment models and getting CMS to figure out how to prioritize equity to a substantive degree that these commercial interests now will see, okay, you know what, there's still some money I can tap into, but it's going to require that I change the way I do business. That's one theory that I'm trying to work on with our group at the Satcher Institute and with our colleagues nationally in our HELEN, our Health Equity Leadership and Exchange Network, to figure out how can we do that? Because I know I have been burned many times as we were working on the Mental Health Parity Act, for instance. I can't tell you, when you look, and I won't call since we're being recorded, but I can't tell you how many employer groups and insurance companies had, stayed close to us, trying to figure out what we were trying to do. And yet you could tell that they were interested in whittling down the policy that we were working on, watering it down to a degree that we believed would not have benefited patients living with mental illness and substance use disorders. And so we had to be very tactful, right? In bringing these insurance companies and employer groups, we had them in one group because I really wanted to understand what is it they were seeking? What was their motivation? Why were they trying to change the parity law, even though we knew from existing court cases that they had done their best to water down the protections? What is it that they wanted to achieve within this bill? And then we had our provider groups and consumers that met in a separate bunch, right? And they could share in a room where they felt, safe and secure in expressing what they wanted. And then I felt like I was playing mediator, right? Between the two groups to figure out, okay, you want this, but I don't want you lobbying against the bill that has taken us 10 years, right? Trying to get it amended, right? To increase the protections for people with mental illnesses and substance use disorders. So we tried our best to play mediator, to give them something, because what they wanted essentially was to get away from this piecemeal approach across the 50 states, where one state was requiring this, another state was requiring whatever. They wanted to have basically a floor, right, that they could follow. Or a ceiling, I guess, is what they really wanted. And then the advocates wanted a floor, right? And how could we meet them halfway? So I think the experiences that we experienced, even with the Affordable Care Act, that was really painful to go through. And it aged me, right? I know it aged many of us who were fighting for the 62 provisions in the health equity, 62 health equity provisions in that law. But again, we had to be pretty savvy to understand what is it they wanted, right? And could there be a compromise of sorts within the bill? And I think what we have learned in the history, even taking mental health reform, for instance, is that it took mental health reformers 150 years after the founding of this nation, where they had been making the moral argument to our government that people are sicker and dying younger, to realize that you can talk about the moral determinants till your tongue bleeds and the government isn't going to listen. But once you align that policy agenda that you're pushing with a commercial interest and a government investment value, right? What's in it for the government? Essentially, how's it going to reduce costs? My goodness, those are the times in this country that we've been able at that federal level to get the policies passed, right? We saw that, and it actually took for mental health reformers to go through 3 wars in this country, the Civil War, World War I, and World War II, before even Dorothea Dix, having spent 40 years of her life trying to push this agenda, going around the country and documenting the abuses against people with mental illnesses, and finally realizing a presidency, Franklin Pierce, where they thought for sure he was going to be the first president to push for comprehensive mental health reform, but he didn't, right? Even though he had observed the terrible tragedy of his son, his only son at the time, to have died in a train accident, and his wife, he saw his wife's health deteriorate from mental illness, and he himself became a substance misuser, an alcoholic. He refused to sign that bill. He basically stated that, okay, it hurts my heart to hear that, you have people who are dying prematurely and so forth from mental illnesses. But unfortunately, that's not the role of the government, essentially, is what he argued. After the 3 wars, when we're now in a dire strait, right, and the mental health of this nation was suffering, in World War II, President Truman, right, working with the mental health reformers, working with our military, right, leaders, and the Surgeon General at the time, they then recognized that, wait a second, if these young people are sicker, right, they're not able to serve in the military, they're not able to contribute to our economy and outcompete our global competitors. That's what the mental health reformers learned in 1946, that they had to tie it to that. Finally, when they did, they got that bill over the finish line. And for the first time in US history, we now had established a National Institute on Mental Health to at least study mental illnesses in this country. And then, of course, our mental health reformers got savvy and they learned throughout the decades, even though it was a piecemeal approach, to tie that to those commercial interests and the government investment value. And every time we did, those are the policies that have been most successful. I know it's probably not what we want to hear, but I hope it answers your question to a degree. All right? Yes.
Yes. You're on the platform, you said you're being recorded and you have to be diplomatic, but we don't have to be that way in the audience. And we don't have to be so lofty. There's a bill now that's trying to reduce the cost of just insulin, right? There are bills now trying to get prescription drugs. I understand that sometimes negotiation and compromise are not dirty words, but sometimes it's political and power. So I think if everyone here supports the candidates that support those bills, we'll be in a better position.
That's right. Agree. All right, everyone.